everyone. I'm Dr. Carmen Puliafito, and I'm here with Dr. Arshad Khanani of Sierra Eye Associates, where he is the Director of Clinical Research and an Associate Clinical Professor at the University of Nevada, Reno School of Medicine. Arshad, welcome back to Retina Synthesis. It's great to have you here.
Thanks, Carmen. It's always a pleasure speaking with you.
So things are moving on with the port delivery system, and we've had some results on their use of the system in diabetic macular edema, and that's what we'd like to chat with you about today. Can you tell us about the study design?
Absolutely, Carmen. So Pagoda was designed to evaluate efficacy, safety, and pharmacokinetics of PDS with refill exchange every 24 weeks, so every 6 months for patients with diabetic macular edema. We enroll patients who are naive. Patients could be previously treated, but the exclusion was no anti-VEGF in the last 6 months. Other than that, visual acuity of 25 to 78 letters, and then CST of 325 microns or greater. And then exclusion criteria, the important ones are no tractional detachment, no high risk PDR. This is a phase 3 program, and we randomized 634 patients. So quite large study, and patients were randomized 3-2 to either receive a PDS implant. In that arm, patients receive 4 loading doses of ranibizumab 0.5 milligram. Then they receive the PDS surgery either at week 16 or 20. And this was compared to a very high bar of ranibizumab 0.5 milligram monthly injections. So the idea was, can we get to the efficacy level that we can see with monthly 0.5 milligram? As you know, the approved dose in the US is 0.3 milligram, but ex-US is 0.5 milligram. So the goal here is to go to even a higher bar of 0.5 milligram instead of 0.3. And the primary endpoint was averaged at week 60 and 64. And this is to establish non-inferiority of PDS with refill exchange every 24 weeks compared to monthly ranibizumab 0.5 milligram injection in terms of change in BCVA from baseline averaged over week 60 and 64. So that was the trial design. Yep.
So it was a 1-year trial?
Yeah, so it's actually the primary endpoint that I presented at angiogenesis was at week 60 and 64, but the trial is actually a 2-year study, would go until 112 weeks and even longer. So, and the goal is we want extension study data in this trial so we can see the long-term efficacy and safety of port delivery system in patients with DME. We have no data in terms of long-term safety or efficacy. As you recall, the original studies and the approval was for neovascular AMD.
So what were the results?
So the main thing is that Pagoda met the primary endpoint. PDS Q24 week was non-inferior to ranibizumab 0.5 milligram monthly injections in BCVA change from baseline average over week 60 and 64. Patients in the PDS group gained 9.6 letters, and patients in treated with intravitreal ranibizumab 0.5 milligram gained 9.4 letters. So really good visual acuity gains in both treatment group. When you look at the visual acuity gains over time, you see initial increase. Obviously, there's a transient decrease in vision after PDS surgery at week 16, between week 16 and week 20. And it's about a line of vision, about 5 letters. And this is related to, just the surgery itself. The eyes are irritated, patients don't see as good. And then this recovers over time. And at the primary endpoint, the visual acuity gains are comparable. Obviously, on top of vision, we want to look at anatomy. And you see the CST, looking at that, we have robust reductions in CST with PDS compared to monthly injection. The curves are essentially on top of each other. And there is a great reduction of CST, almost 200 microns in both treatment groups. So efficacy-wise in terms of vision gains and CSU reduction, this appears to be very promising. And this was achieved with greater than 95% of patients not requiring supplemental treatment. So if you recall, patients were refilled every 6 months or 24 weeks, but 4 months after the surgery or 4 months after the last refill, they had an opportunity to get supplemental injection based on pre-specified disease activity criteria. So majority of the patients, greater than 95%, didn't meet the criteria and didn't need treatment. So what we are seeing here is long-term sustained delivery can have great efficacy in terms of controlling anatomy and improvement in BCVA while reducing treatment burden. The other thing we looked at was DRSS improvement, and we saw significant improvement in DRSS in the PDS group, which was a 2-step or greater improvement of 39% compared to 42% in the intravitreal injection group. So that was also promising. And you know that the Pavilion trial also met the primary endpoint where PDS was looked at in patients with diabetic retinopathy. And that trial also met the primary endpoint. So now we have positive DME and DR data with PDS.
Fantastic. Any safety issues?
Yeah, so, it's a surgical procedure. So we expect PDS patients to have more ocular AEs, whether it's subconjunctival hemorrhage, whether it's other events. But the main things that we saw in the neovascular AMD trials were conjunctival retraction and erosion. And as you know, for the neovascular AMD, there's a black box warning for endophthalmitis. So I'm happy to report that there were no cases of endophthalmitis seen in this large phase 3 Pagoda trial, and there were no cases of retinal detachment. There was one case of implant dislocation, and there was one case of septum dislodgement. The other adverse events of conjunctival retraction, erosion, and vitreous hemorrhage, those are events that we have seen in neovascular AMD, and it appears that the conjunctival issues have decreased in terms of the percent rate. So I think what we have learned over the years is that what is the proper technique to open and close the conjunctiva and tenons. And if you don't do a good job with that, you actually end up with risk of endophthalmitis. So I think the evolution of surgical technique over time and really paying attention to key step likely has resulted in better safety that we have seen in Pagoda, also in Pavilion, compared to neovascular AMD. And the other thing is this is a different patient population also. Younger patients may have better conjunctiva and tenons, so that's yet to be compared whether it's the patient population or the surgical technique. But I believe that it's really changes in opening and closing that has really led to minimizing this. And I look at my surgery from phase 2 ladder study from 6-7 years ago, and I look at my surgeries from Pagoda and Pavilion, they look much, much better because we are doing things in a different way in terms of closing and opening the conjunctiva and other key steps.
Now, this is really exciting. I mean, this is a new dimension of success in treating a chronic disease where multiple interventions are frequently required and are frequently not done.
Yeah, no, I agree with you. And I think this is the first trial showing the value of sustained delivery in patients with DME. Carmen, you and I know that we have a lot of patients who are suboptimal responders to anti-VEGF. Some people code rates from anywhere from 10 to 30%, even up to 40%. And I think what Pagoda is showing to us that if you have continuous delivery of anti-VEGF, you can really maintain good disease control as well as improve vision in majority of your patients. And I think that's exciting for the field. And these are younger patients who have a high treatment burden. they're even more non-compliant than patients with neovascular AMD. Now, of course, it's a surgical procedure, so you have to look at the risk and benefit for each patient and discuss that. But my patients in the study have been really, really happy. Many of them have fellow eye disease where they get anti-VEGF injections, and they're asking, just like my neovascular AMD patients, I have multiple patients with neovascular AMD where they were one eye, they got the implant in the study, and then when it was FDA approved, they received it in their fellow eye, the commercial implant. And I'm seeing the same with diabetic macular edema patients because they can see the stability of their vision, but also the reduction in treatment burden. Obviously, you're aware that PDS have been voluntarily recalled at this point because of some manufacturing refinements that they're doing. There were cases of septum dislodgement. The rate was not super high, but significant for them to voluntarily recall it. It was between 2 to 4%. And I think we need to have the next generation available in the future so we can really help our patients with neovascular AMD as well as diabetic macular edema.
Yeah, the data set is powerful, and we really hope that that Genentech works out the issues with the septum.
Yeah, I hope so too. I hope it's done sooner than later because patients are waiting. And Carmen, you practiced for a long time, and you know that surgical technique and technology evolves over time. So I think as a field, we need to understand that we need to see a progress in terms of lowering the adverse events and making surgery better with training and following all the steps. And that's the exciting part about Pagoda and Pavilion data, that we actually see that proper training, proper technique, refinement of closure and opening and wound size and other things have improved the safety profile, because we have great agents currently available with intravitreal injections with now faricimab that is available with dual inhibition that can go longer. So I think any surgical technology or sustained delivery technology, whether it's PDS or gene therapy, I think the safety is important, and it's nice to see that there were no cases of endophthalmitis seen in Pagoda as well as Pavilion trials.
Great. Well, thanks a lot for your contribution to retina synthesis, Arshad.
Always a
Thank
pleasure.
you.
Always a pleasure to be speaking with you, Carmen. See you soon.